Balamurugan, good afternoon.
YouTube लाइव पे होगा।
Balamurugan, good afternoon.
Hello. Listen, good evening to one and all.
Sir, we are able to hear you, sir.
Good. The video clear? We are able to hear you, sir. Thank you. The video clear? Yeah. Pleasant good evening to one and all. I think the listeners can mute the screen. A pleasant good evening to one and all. Being on time is such a good thing. So we need to start our presentation. The topic we have chosen is Behcet's uveitis. What's new in the diagnosis and management? A lot has changed in the diagnosis as well as the management of Behcet's uveitis. So a lot of clinicians have problems in first picking up the diagnosis as Behcet's, and once the diagnosis is done, we need to go full to give the best possible care with the latest updates that has happened in the last decades. So let us update ourselves with the recent changes. Can you have my PowerPoint, please? So I thought we will evaluate ourselves at the beginning of our class with a set of questions so that we get focused to what we are trying to identify ourselves in the Behcet's disease. At the end of the class, we will ask ourselves the same questions whether we are clear with the ideas or concepts or not. So let us have a set of multiple choice questions at the beginning. So all the listeners can try to note the answers in a piece of paper or even in your mobile, so that at the end of the class, you ask yourself whether you have cleared yourself. How do you know? It's not happening. Okay. No. Yeah. The first question, all of the following findings are seen in Behcet's uveitis except A. Hypopion pan-uveitis, option B. granulomatous pan-uveitis, peripheral anterior synechiae without tenting, the fourth option, periarteritis, more common than the periphlebitis. So the question is about except, so we need to choose one which is odd man out. Moving to this question number 2. The following TNF alpha inhibitor is not indicated in Behcet's uveitis. A. Anakinra, B. adalimumab, C. etanercept, D. infliximab. The question is about not indicated, although it is a TNF alpha inhibitor. Question number 3. The first line of drug for treating an hyperacute Behcet's uveitis waiting for confirmation is A. cyclosporin, B. azathioprine, C. parenteral steroids, D. infliximab. The question is for hyperacute waiting for confirmation. What will be the first line of drug? Is it cyclosporin, azathioprine, parenteral steroid, or infliximab? Good. Question number 4. Which drug causes reperfusion of the occluded retinal blood vessels in Behcet's uveitis? Looks like a wonder. A. interferons, B. infliximab, T. tocilizumab, option number D. adalimumab. Which drug causes reconstitution of the disrupted retinal layers in Behcet's uveitis? Is it infliximab? Is it interferon? Is it tocilizumab? Or is it adalimumab? Good. So let us start our class now. So whatever you see good in my presentation are not because of mine, it's because of my teachers. And whatever bad, I take my responsibility for making it better at the subsequent time. So this is not what I said, this is Swami Vivekananda. I would like to start the presentation with this quote. Yeah. Next slide, please. So we all know Behcet's is one uveitis which followed the Silk route. See, earlier there were silk traders moving from one part to another, and India was also a part of the Silk Road. And like our coronavirus, it also was having a geographical predilection, moving from one continent to another continent. So it all started from in about 3 lakh years to 30,000 years ago, and moved to Siberia, from there to Alberta, North America, South America, throughout the world. It came roller coaster. Next slide, please. So what is very fancy of Behcet's is it respects a particular latitude and longitude. If you see, most commonly the occurrence occurs between 30° north to 45° north. So it's quite curious for some of the geographical analysts to see this predilection. Next slide, please. So there are multiple diagnostic criteria to diagnose Behcet's. So they gave multiple points for a different manifestation. Oral aphthous carries 1 point, skin manifestation 1, vascular lesions 1. They did a pathology test for which they gave 1 point, genital aphthous 2, ocular lesions at 2. But practically, we are not using all this because to do pathology tests and the diagnosis is certain if 3 or more points are there, and they gave a sensitivity of 96 and specificity of 89%. Next slide, please. So again, the Japanese people, they are unique in their own ways, and they gave a new criteria called major criteria or minor criteria. The major had again this recurrent oral aphthous, skin manifestation. The ocular manifestation was good enough to be a major criteria, and genital ulcer. It's easy to remember. The minor criteria include arthritis, epidermitis, ileocecal sores, vascular lesions, and the CNS lesions. They are all grouped under the minor criteria. They gave complete, incomplete, and specific types like Entero-Behcets, Vascular-Behcets, Neuro-Behcets. So all these combinations of major, minor were there in the Japanese criteria. Again, this criteria is not practically applicable. So what then is applicable? Next slide, please. So first, before seeing how to diagnose Behcets, let us analyze how each of the symptoms is going to be. Recurrent aphthous. It is, as the name says, it is going to be in the buccal mucosa of the mouth, gingiva, tongue, lips, palate, tonsils. It can be there in the pharynx and the esophagus. They are classically described as a painful small round ulcers with clearly defined borders. They characteristically heal without a scarring response, which is unique in Behcets. Next slide, please. The genital ulcers, as you know, it's seen in the genital area, they heal with a characteristic scarring response. So look at the difference here. They heal with a scarring response. The skin manifestation include the erythema nodosum, the folliculitis, or they sometimes do this Pethardy test. When the skin of these Behcets patients are pricked with a needle, they get an area with a sterile pustule after 24 to 48 hours. So this is a very, very simple test to do, but it is not very specific. It can be there in various other manifestations. As we look at the sensitivity, is 43.8%. So the ocular manifestations include, first let us start the anterior segment. Characteristically, the Behcets uveitis is known for a mobile hypopia, and it is recurrent, keeps on coming, and the hypopia and uveitis, a lot of people make it synonymous with Behcets, but it is not so, because the most common type what we see in our practice is HLA B27 uveitis. How to delineate Behcets from HLA B27 is very, very simple. So the Behcets hypopyon is characteristically mobile, whereas the HLA B27 is immobile. The reason being the fibrinous content in HLA B27 is very, very dense, whereas in Behcets it is much lesser. So that's why mobile hypopyon is almost synonymous with our Behcets. So we need to always delineate the characteristic of the hypopyon. And the posterior synechiae is so common, and they can lead on to iris bombi formation as well. So the most important point in the corrective precipitate is they are unlikely to be mutton fat corrective precipitates. Mutton fat, as you all know, is a granulomatous KPs, because this is a unique phenomenon of Behcets. The pathogenesis, the complements involved in the disease process makes them to be hyperacute, virulent, and non-granulomatous. We always think that the granulomatous uveitis is more aggressive. But Behcets is a unique exception because although it is non-granulomatous, it is an hyperacute, virulent uveitis. When untreated, these Behcets can also have a rubeosis iridis. To do a gonioscopy, you see a peripheral anterior synechiae without tenting. So this is very, very important. If you see a sarcoid case, the tent-shaped peripheral anterior synechiae, if you recap, is one of the diagnostic criteria to pick up sarcoidosis. Whereas PAS without tenting is characteristically seen in Behcets uveitis. So if you see a tenting PAS, you need to always think whether are you dealing with Behcets or not. As I said, the most characteristic point is if you have granulomatous KP, you are almost sure that you are not going to be dealing with the Behcets uveitis. To recap, name one another uveitis where granulomatous KP is unlikely. Can they answer? Yeah. Can anyone finger or try to answer? Name one another uveitis where the KPs cannot be a granulomatous type. Anyone in this audience? Yes. Good. HLA B27 cannot be granulomatous, but there is one exception of inflammatory bowel disease where it can be granulomatous. There is one another uveitis where if it is granulomatous, you are almost sure that the uveitis is unlikely to be of particular subtype. It is that type of uveitis which we see more in South India. It is, I'll give you a second clue. It is one of the uveitis where the South Indian doctor formulated the international diagnostic criteria. The international criteria for this disease was formulated by none other than our own Aravind doctor. I think I gave away the answer. Yeah, it's very clear. It is leptospirosis. Leptospira is one another uveitis where it cannot be a granulomatous type. It is always or strictly a non-granulomatous variant. Similarly, in Behcet's also, you don't see a granulomatous type of keratic precipitation. We always sometimes when we see the KPs, we just write KPs. We don't bother whether it is granulomatous or non-granulomatous. For me, it is like writing a cataract. So if I write in a free hospital seeing a cataract, you will laugh at me, isn't it? I don't write immature, hypermature, leaking Morgagni and the subtype. Similarly, whenever you see a KP, you have to characterize them well so that the people who see you actually respect you, that you paid attention to each and every finding that you have evaluated. Yes, good. So the posterior segment manifestations are very, very important because they are vision threatening. So the vasculitis, as we know, the arteritis are more commonly involved than the phlebitis. So the veins are very less commonly involved. It is exactly ulta of sarcoidosis. Sarcoidosis, you know, it is predominantly a phlebitis, and it can have a retinitis. Retinitis is more commonly a retinal involvement or retinal edema sort of type with perivascular involvement. There can be optic nerve edema and as well as the macular edema. Retinal vasculitis with vitritis is documented as an universal finding of classical Behcet's uveitis. Characteristically, this vasculitis is known for a lot of CNP areas. The CNP is massive, almost 360-degree CNP areas. Of course, when there is a lot of CNP, there will be more neovascularization, there can be more of vitreous hemorrhage as well. Upon resolution, these inflammatory cells accumulate in the inferior pre-retinal area, forming a characteristic pearl necklace appearance. Yeah. So in practice, this is what I want you to remember. Whenever you see a patient with oral actus, ask yourself, this is a patient has a genital actus or not. If it is present, possibility of Behcet's is there. If it is absent, search for the ocular signs. If it is present, definitely you are likely to deal with the case of Behcet's. If it is negative, you are good to do a pathology test. If it is positive, look for the skin manifestation. If it is present, Behcet's is likely. The skin manifestations are not there, Behcet's is unlikely. Of course, if the pathology test is negative, there is no Behcet's. So looking at the other arm, if there is ocular sign, and we will do if ocular signs are suggestive of a Behcet's, definitely we will be looking for a pathology test. If it is present, Behcet's. If it is absent, again go and look for the genital manifestations. If it is present, Behcet's is likely. If it is absent, there is no Behcet's possible. So this is one practical algorithm which we need to apply in a real-time practice rather than all the Japanese criteria, international criteria, and breaker head. So I think this is one take-home message from this presentation. So how can you look at the picture and suspect Behcet's? So look at the characteristic fundus photo or FFA picture. You see a lot of perivasculitis, macula involving, lot of macular ischemia. See, the posterior pole is almost not perfused. There is an enlargement of FAZ. As you see, there is a lot of hemorrhages, lot of ischemia. Definitely, you will be searching if there is arteritis predominantly involved and phlebitis and look for Behcet's signs. So again, these are the peripheral manifestations. You need to see a lot of ischemia, hemorrhage, neovascularization. Again, Behcet's you need to keep in your mind as whether are you dealing with this. Again, there are a lot of neovascularization on the disc and along with retinitis close to the disc. Again, we'll all keep the Behcet's high on the list. These are the other pictures. And the most important thing I want you to take in your mind is a fern-like pattern that you see in the fundus produced in angiogram. If you see that there is a adjacent picture how a fern is going to look like, how our FFA is looking like. There is an analogy here that looks like a fern, and this is very, very characteristic of Behcet's uveitis. So to note, fern-like pattern is more commonly seen in Behcet's. Of course, it can be seen in other type of vasculitis also. But whenever you see a fern-like pattern, always keep Behcet's high on the list. So a lot of people have graded the FFA findings and the leakage into different grades. Of course, you may think that it is for a level of fellows, but we need to keep in mind. So when there is grade 0, there is no sign of vascular staining or leakage. Grade 1, there is staining of the vessels with minimal leakage. Grade 2, there is intense leakage with distinct vascular margin. Grade 3, there is a leakage with blurring of the vessels versus the margin. So these are the FFA findings. Of course, the ischemia can lead on to edema, neovascularization, and multiple CNP areas. So the OCT findings, especially the EDA OCT findings, are very, very pathognomic. If you see the picture here, there is the enhanced depth imaging of the OCT is able to pick up the enlargement or the choroidal ischemia, the increased choroidal thickness, which can be used as a marker of the disease activity. You can use it to monitor the disease activity during follow-up, because as you know that the OCT is a non-invasive test to easily monitor the disease activity. So the examiners are very fond of asking the HLA association of Behcet's. So the HLA associations are varied. Actually, the most common one is HLA B51. Don't pronounce as B51, it is B51. It's more common in an ocular. HLA B27 is more common in arthritis. B12 more suggestive of a mucocutaneous variant of the Behcet's. To recap, HLA, as you know, stands for human leukocyte antigen complex. And where is the chromosome located? It's located in the petit or the short arm. Okay, so it has A, B, C. Different genes are loci are there. B51 is so common in Behcet's. Don't be misled when I say that B27 is also seen in Behcet's, because we think that B27 is standalone for actually B27 uveitis, but it can be seen in Behcet's as well. So as a clinician, what I'm going to do when I see a case of Behcet's is to rule out the differentials. If you rule out the differentials, the treatment is going to be very, very straightforward. The commonest differentials are the acute retinal necrosis. It is very, very difficult to delineate. Of course, any other uveitis like TB, toxosarcoid will come into the list. Of course, the syphilis, aspergillosis, masquerades are all coming lower down on the list. So how to delineate each of the things as enumerated in this tabular column. The reactive arthritis, there will be the diagnostic criteria, you can apply them. Seronegative arthritis, mainly there will be the diagnostic criteria finding aortic insufficiency, axial involvement, enthesitis, acroiliitis, they are all going to help. More commonly, as I said in the beginning of the class, the mobility of the hypopion versus the immobile hypopion will give you a clue. The inflammatory arthropathy, there will be the serological abnormalities. Again, the inflammatory bowel disease, the bowel involvement will give you a clue. The multiple sclerosis, you may have a neurological manifestations. Again, the sarcoid, as I said, the characteristic of the peripheral angiosynic as well as the granulomatous KP as well as the hilar retinopathy will give you the clue. The other vasculitis, there will be anomalies in the vessels, aneurysms, and ANCAs will give you the clue. BKH, there will be again the diagnostic criteria is going to help. SJS, again the diagnostic criteria as well as the blisters and the corneal involvement with dry eye is going to give you the clue. The venereal disease, you will be ordering the specific tests like TPHA, and those are going to really help. Any uveitis, the complications are very, very simple. It is like copy paste. So there will be cystoid macular edema, secondary glaucoma, optic atrophy, of course the macular ischemia causing vitreous hemorrhage, neovascularization on the iris, a complicated cataract, and if not treated properly and picked up, can go on for phthisis bulbi. of all the complications, which of the complication is so pathognomic or so common is this optic atrophy, because people seldom pick up the diagnosis or seldom going for starting immunosuppressants. They keep on giving steroids. This Behcet's uveitis is known to be steroid resistant. Steroid standalone are not the treatment of Behcet's uveitis. Yes. Shifting gears, what is the aim of the treatment? So whenever we do any treatment, we need to have something called aim. What are we going to do treating the case of Behcet's? Treat the activity and control the chronicity of the disease, as well as plan for decreasing the number of relapses. So before planning treatment, we need to have some parameters before telling the patient this is going to be the visual outcome you are going to get. These are going to act as a predictors of visual outcome. Male sex is found to be a good or bad predictor? Bad predictor. Macular ischemia, of course, is going to be a bad predictor. Increased macular thickness with EDOCT is going to be a bad predictor. Choroidal thickening in the active phase, again, is a poor prognosticator. The posterior pole involvement, more severe it is, the disease is going to behave in a very violent way. The more the activate is, more the involvement. Of course, the young age comes at the last in the list. The most important thing in our practice which we need to do keep in mind is, of course, Behcet's is more common in male, and you do an EDOCT, shows a lot of choroidal thickening. Keep in mind, you are going to have a very, very aggressive form of Behcet's, and we need to press the accelerator full to plan the further course of treatment. So there are different ways to treat Behcet's. It's they solve for the rheumatologists. For a mucocutaneous, they start with NSAIDs, topicals, antivirals. Musculoskeletal, the colchicine corticosteroids are going to help. It's our area, how to treat the ocular symptoms. So we have azathioprine, cyclosporine. What is FT516? It is it's a sister of cyclosporine. It is tacrolimus, thalidomide, and sulfasalazine. This is our area. Of course, whenever we deal with interferons and TNF alpha antagonists, we need to team up with the rheumatologist and start with the treatment. So, why I put this slide? Because there has been a paradigm change or shift in the planning the treatment. Earlier, there is something called step ladder approach. We start with steroids, then immunosuppressants, then the second, another immunosuppressant is added, finally the biologics are added. Now there is something called elevator. People are bored of climbing the stairs with each steps. So we have an elevator. Directly go with the biologicals. We got the Colombo Retinal meeting 2016, which we attended. They postulated first that we need to change our treatment plan in Behcet's, directly use our elevator, don't be climbing each stairs, directly go with the biologicals as the first line of management. Of course, this has got its own limitations in our Indian scenario. We'll discuss it towards the end of the class. There is something called the recommendations. EULAR stands for European League Against Rheumatism. It gave multiple recommendations. The first two recommendations are the most important, and they said it's relevant to ophthalmologists. So what they said is, any patient with Behcet's inflammatory eye disease affecting the posterior segment to be treated includes azathioprine as well as systemic steroid. This is the recommendation number one. Recommendation number two, whenever there is a drop in the vision with retinal vasculitis or macular involvement, it is recommended that either cyclosporine or infliximab used in combo with the above two drugs. That means if there is a vision drop, you also need to add infliximab or cyclosporine. If you don't have all this, there is an alternate, like you can use an interferon alpha with or without corticosteroids could be used if the patient is off-roading. So the first two recommendations are irrelevant to ophthalmologists. We as ophthalmologists are directly able to assess the disease happening in the body, and whereas other specialty people are not able to access them. And we are in a very good scenario to monitor the treatment as well with the EDOCT as well as the fundus fluorescein angiogram. Okay, so what is this azathioprine? So azathioprine, the earlier recommended as a first line drug. And as the second recommendation says, whenever there is a posterior pole getting involved, you are going to combine with systemic corticosteroids and add one more drug. So the Euler also recommended with multiple randomized controlled trials based on 7-year follow-up, they came up with a dosage of 2.5 mg per kg per day, and they proved that the vision was stabilized and they decreased the development of the other eye getting involved as well. They also proved that the hyperpon uveitis are needed to treat is reduced whenever you start azathioprine as a first line of management. So remember, this is a sort of what do you call renaissance in the Euler recommendation, because people really believe that the first line of drug for Behcet's is always cyclosporine because it is a T cell mediated disease. But the Euler surprised everyone, telling that azathioprine is the first line of drug in Behcet's uveitis. Why is it? We'll come to know towards the end of the class. Again, as per the Euler, this corticosteroids also have a role. So, but the beauty of corticosteroid is there is no one who has done a randomized controlled trial to prove that corticosteroids are the first line of drug in any sort of aggressive uveitis condition. Because the reason is very simple. You don't do a randomized controlled trial telling that sun always rises in the east and sun always sets in the west. If you do an RCT, everybody will start laughing at you. Right. Corticosteroids rapidly suppress inflammation. We all know that it can cause potential side effects like cataract glaucoma. Of course, as I said, corticosteroids stand alone are not going to help, because Behcet's uveitis is characteristically going to be steroid resistant. Steroid stand alone will not help, but still we need to use steroid because they are the first line of drug, because steroid is going to act immediately. Right. So that's what we mean. The refractory ocular disease, whenever there is a drop in the vision, we are going to add the cyclosporine A or infliximab. Alternatively, you can use an interferon with or without this IV steroids. So the cyclosporine, there are multiple randomized controlled trials. You know what is a randomized controlled trial, isn't it? It's a head-to-head comparison. And this cyclosporine is really a wonder drug for Behcet's, because I used to say that cyclosporine and Behcet are like twins, or they act like lovers. They are inseparable twins. So the Behcet's and cyclosporine are inseparable. So we also, in our beginning period of practice, we always preferred cyclosporine. Of course, with these recommendations, we started changing our practice patterns. So what is beauty of cyclosporine is, cyclosporine won the battle against cyclophosphamide. See, there are different levels of immunosuppression, level 1, level 2, level 3, level 4. All our IOL Pondicherry postgraduates know what the level 1 denotes. Level 4 is the highest level. Level 4, we have the cyclophosphamide. So when cyclosporine was compared in a randomized controlled trial with cyclophosphamide, it came as a big surprise. The number of patients having recurrences, the efficacy of the treatment was much superior in cyclosporine rather than cyclophosphamide. This was really an amazing randomized controlled trial, and people started using cyclosporine as a first line and the beginning period of our practice, and it all changed now. The also, as I said, it reduces the frequency of the attacks as well as the severity of the ocular attack. Of course, it all comes at the expense of the side effects. So like hypertension, nephrotoxicity, right? So there are some emergencies in Behcet's, like there can be a deep vein thrombosis with steroid azathioprine, cyclophosphamide going to help. There will be aneurysms, you have to start with cyclophosphamide. Okay, the neurological involvement in Behcet's is also an emergency. There is no data to exactly guide the treatment, but the parenchymal involvement needs corticosteroids, interferons, azathioprine, cyclophosphamide, and the other drugs. So the neural sinus thrombosis needs an acute treatment with corticosteroids IV, right? Whenever there is a joint involvement, arthritis, colchicine is going to really help. The other drugs are going to prevent the long-standing disabling attacks, right? So this is mainly for the internist, but as ophthalmologists, we need to know that there will be multiple systems getting involved, like the brainstem involvement, cerebellar involvement, there will be a motor paralysis, hemiplegia, weight disturbances, dysarthria, diplopia, psychiatric manifestation, as well as the personality changes. So these all could be there in a Behcet's patient as well. So markers of disease activity, there are so many molecules that are identified in several studies. The practical one is very simple to remember. It is erythrocyte sedimentation rate as well as C-reactive protein. In addition, we have the other selectins, AOPP, serum beta 2 microglobulin, all this are there. Don't worry about all this, but at least pay attention to the erythrocyte sedimentation rate. Because whenever we order the investigations, we are so busy that we don't look at the ESRS. So at least in Behcet's and other autoimmune conditions, we need to pay attention to the ESR as well. Okay. So I said the lot has changed in the treatment of Behcet's. There was this article on expert panel recommendation for using TNF alpha biologicals in ocular inflammatory disease, and the first one, look at it, infliximab adalimumab can be considered as a first-line drug for ocular manifestation of Behcet's, right? So that was a paradigm shift. That was what about this, we are telling about the elevator approach. So whenever you are sure of the diagnosis of Behcet's, press the accelerator, go full, start with infliximab adalimumab. That's what this article from US said, because they had the facility to do. But in India, we have our own problem. So they also came with some strong recommendation, discretionary recommendation. So first or second line anti-TNF good. Ocular BD, it can be used as a corticosteroid sparing drug. Acute exacerbation, we are good to use an infliximab, right? Remember, whenever you have an acute exacerbation, infliximab can also be tried whenever you are sure of the diagnosis. The problem is picking up the diagnosis. So that is a real problem, because the close differential acute retinal necrosis, if you happen to treat with all these TNF alpha inhibitors, it is going to really progress unless you give specific antivirals in ARN. So the discretionary recommendation, they said that etanercept is intolerant to infliximab adalimumab. Towards the end of the class, you will see that how this drug again failed, right? The calcineurin inhibitors, the two drugs are there. We said tacrolimus and cyclosporin. Cyclosporin, as I said, won the battle against the cyclophosphamide. It has favorable side effects, especially in mucocutaneous and the systemic form of the Behcet's. As I said, the side effects of cyclosporin all starts with H: hypertension, hypertrichosis, hyperlipidemia, hypertrophy of the gingiva, and hyperglycemia. Of course, the nephrotoxicity, neurotoxicity always needs to be remembered. And whereas the side effects are going to be less when you use the sister molecule, that is tacrolimus. So, shifting gears, we always think that biological is equal to TNF alpha inhibitor. It is not so. The initial biological that came in the research was interferons. It was used early in the 1980s. But the thing is, whenever you start interferons, we need to stop the immunosuppressants. Whereas when we give a TNF alpha inhibitor, we need to give both together to prevent the development of antibodies to the biologicals. Biologicals themselves are an antibodies to a TNF alpha. So there is a phenomenon called antibody against antibody. So to prevent that, immunosuppressants has to be given whenever we give TNF alpha inhibitor. Whereas in interferons, we are not supposed to give immunosuppressants as they are going to antagonize the action. Right. This was this beautiful study which showed that these interferons can beautifully open up the closed blood vessels and cause a complete regression of the retinal neovascularization. Looks like a magical drug for the initial people who handle this drug, right? So the side effects, of course, there can be a flu-like symptoms. So whenever you see flu now with COVID days, we are really worried about it. And it can cause depression, neutropenia, elevated enzymes, epilepsy, and injection side effects. So interferon alpha does not predispose to increases of infections, unlike the TNF alpha therapy. So the only problem is the cost. So it is getting popularized in Germany, where they prefer the interferons rather than the TNF alpha inhibitors. There are multiple TNF alpha inhibitors, infliximab, adalimumab, golimumab. So all ends with mab, right? So that means monoclonal antibody, right? So etanercept is something different. and certolizumab is again a MAB drug, right? Infliximab, as the name says, is a chimeric anti-TNF IgG1 monoclonal antibody. It is going to neutralize the membrane bound as well as the soluble TNF alpha. It suppresses the TNF alpha production by macrophages and lymphocytes. It has got its own T-off and dosage, all you can forget. But remember, this was multiple studies have proven that it's going to be really, really useful in Behcet's, and it was approved by Japanese Ministry of Health for refractory Behcet's. The problem is the risk of getting TB. You know that in developing countries like India, TB being super common, there is also a risk of malignancy, not to forget the multiple sclerosis and lupus-like reactions. So whenever you start infliximab, you are supposed to order a CT brain to rule out multiple sclerosis, CT of the thorax to rule out TB in particular in Indian scenario. Of course, be very, very clear that you are not dealing with a case of masquerade, because there is also a risk of malignancy forming, trying to treat an aggressive disease. What is very interesting is the reconstitution of the disrupted photoreceptor layer, which is happening in this wonder drug called infliximab. So this really fascinated a lot of people who do a lot of studies on this drug. So there is another sister drug called adalimumab. It is different from infliximab because it is fully monoclonal or is fully humanized form. So again, it binds to both the receptors, and the difference here is it's given as subcutaneous, whereas the infliximab has to be given as IV. So we are allowed to give any drug as subcutaneous rather than giving IV, isn't it? So that's why adalimumab is getting popular. And again, there are multiple studies which say there is a complete resolution of inflammation by week 4. Which drug is better? Either infliximab or adalimumab. There is no head-to-head comparison. Unlike you have in JAA, JAA also is one another autoimmune condition where infliximab, adalimumab are the popular drugs, but there are studies which say that adalimumab is much, much superior to infliximab, whereas in Behcet's we don't have such studies. But common sense should dictate, isn't it? It is fully sort of humanized form, and it can be easily given as subcutaneous. We'll always go in for adalimumab, given an option, right? So the limitations of TNF alpha inhibitors, as I said, the high cost, there is going to be multiple injection, toxic side effects. So when are you going to stop the drug? Nobody knows it. When is the COVID going to end? We all don't know. Maybe after some time it will stop. When are we going to stop TNF alpha inhibitor? Nobody knows. Maybe we may have to give once in a month, once in 6 months, once in a year, but nobody knows what is the end point. So the other agents like canakinumab, jivakumab are also there. It blocks the IL-B antagonist, and the tocilizumab, it's very, very good drug. So in the COVID era, we all need to remember this drug. You know why? Not that it is antagonizing the IL-6. IL-6 or interleukin-6 in one cytokine, which acts as a master cytokine to control all the other cytokines. It's sort of leader cytokine. So it acts like our CMO, right? Controls all the medical officers. So why tocilizumab is important in the COVID era? So the cause of death in COVID-19 is not the infection, the virus causing problem. It is your immune system trying to overreact against the body system. So tocilizumab is found to be helpful in treating the COVID infection in SARI cases. You know what is SARI? Severe acute respiratory infections, because it controls all of the cytokines. I don't know how many of you have read those articles. So don't forget tocilizumab. So it is also useful in Behcet's. So when you read Behcet's, you can also have some understanding of COVID, because tocilizumab is approved in several countries in SARI cases, severe acute respiratory infection following COVID. Right. So rituximab, what is this? This is a CD20 blocker, right? So all these are interleukin, whereas this is CD20. Okay, so name one disease where rituximab is a drug of choice. Yeah, drug of choice. The first leg of choice in vaginous or GPA. Granulomatous polyangiitis, the first line of drug is rituximab. Name one malignancy rituximab is going to be helpful. Yeah, very, very simple. You all know that. It is, yeah, B-cell lymphoma, because it is an antibody against the CD20, right? So whenever you have an intermediate uveitis mimicking as malignancy or B-cell lymphoma, and you are supposed to do the CD20, if it is positive, you are going to plan rituximab. That apart, these are also useful in Behcet's uveitis, right? So I'm trying to take you out of the topic, but stay to the topic, right? So there is something called do's and don'ts in Behcet's. Certain combinations are forbidden. See, the two coals are two drugs starting with C, that is colchicine and cyclosporine, shouldn't be combined because they can induce myopathy. And there is lack of evidence in using anakinra and Behcet's uveitis, although it is a TNF alpha inhibitor. In pregnancy, you are not supposed to give colchicine because it can be teratogenic. The most important fuel I want you to remember in the practice is cyclosporin is contraindicated in Neuro-Behcet. In fact, there is an entity called drug-induced Behcet. We in uveitis, for every disease, we have something called drug-induced. Drug-induced Behcet, cyclosporin is one drug which can cause drug-induced Behcet. So that's why I said these two drugs, the Behcet and cyclosporin, are so fan of each other that when you start treating Behcet with cyclosporin, after some time it can cause Neuro-Behcet as well. So that's why it's being taken off as a first line of drug, although in the initial practice we can be very useful. The most important point is etanercept, although it is a TNF alpha inhibitor, is not at all useful in practice, and for that matter, any way it is for that practice. If you see the older textbooks or any older presentation, they will start telling TNF alpha inhibitor, etanercept, infliximab, adalimumab. So those are all the days gone, because uveitis, like any other branches, keeps drinking Complan and Horlicks and keeps growing day by day. And we need to keep in time and stop growing with the disease, otherwise the advances will outnumber where we are. So unmet needs. What do you mean by unmet needs? When to initiate therapy? Which agent and dosage? How long to treat? Nobody knows. So we need to do some randomized control trials to answer these queries. Biologicals are reserved for refractory in the early era. Now there are so many companies trying to address this problem of high cost, and the long-term experiences are avoided. And the last but not least, we need to start the treatment early, embrace the evidence in favor of anti-TNF alpha therapy for Behcet's uveitis. This is what the editorial from British Journal of Ophthalmology said, right? So take-home message, there is no single treatment that is going to fit everyone. So if you go to a shop, not all size will fit all the people, no? So each person is going to have a custom-made treatment, right? Ruling out TB is very, very important, not only in India, even in abroad, because after starting the biologics also, the patients are more susceptible to get TB. So ruling out TB at each and every step during follow-up is very, very important. There is no single best treatment, as I said. So in practice, when you see a Behcet's, what are we going to do? Assess the inflammation. Always try to look for the etiology findings, which is going to be really, really helpful to tailor make the treatment. You can either step up or step down. Of course, all our presentations ends with this slide. Intelligence and capabilities are not enough. There must be joy of doing something beautiful. Hope the lecture was interesting. I'll be happy to listen to some queries. Okay, if there are no queries, shall we go back to our questions and enlighten ourselves what the answers were? Huh? Yeah. So, I think most of you would have answered the questions correct. All of the following findings are seen in Behcet's except hypoplan candidates, yes. Granulomatous, no, strictly non-granulomatous. Peripheral anti-ischemic without tenting, of course. Arteritis more than fluid, good, looks easy. Second one, the following TNF alpha inhibitor is not indicated in Behcet's. Is it anakinra? Is it adalimumab? Is it etanercept? Is it infliximab? So all these are TNF alpha inhibitor. You all agree that? Yes. Etanercept, you will say not useful. Name one another drug. Anakinra. Good. That doesn't mean that you should have one answer. No, you can have two answers, right? Yeah. Next question. Wow. The first line drug for an hyperacute basis, waiting for confirmation. Waiting for confirmation, what will you give? Yeah. So, will you give cyclosporine? What is the problem? So, cyclosporine, if you start, it will have a lag period for 4 to 6 weeks to start acting. The same with any other immunosuppressant, infliximab. Can it be infliximab? Yes. If you are in US, you can give parenteral infliximab. Even the EULA recommendation said, isn't it? So, but I did not mention it is parenteral. So parenteral steroids will be a prudent option, although parenteral infliximab could also be tried, right? Azathioprine will have a lag period for 4 to 6 weeks to start acting, right? Which drug causes reconstitution of the disrupted retinal layers? Reconstitution of the disrupted retinal layers. Is it infliximab, interferon, tocilizumab, adalimumab? Infliximab. Good. So you got confused here. Huh? The wonder drug which opens up the ocular retinal blood vessel is interferon. It's not infliximab, right? So hope this. I'm not sure how many of you had answered the last two questions correctly at the beginning of the class. Okay, good. Fine. Is there any queries? I'll be happy to. Yeah. If you have any other queries pertaining to UVHs, you are always good to ask me. Yeah, you can raise. Yeah. ESR, there is Dirmula Sudhamala. She has asked, ESR is raised in all types of UVHs, so how come this would be differentiating point to be paid attention? Okay. So, yeah, that is a good question, right? So, ESR is not very pathognomic. What we try to say is there is an inflammation going on, but ESR is terribly raised. More than, before that we need to know what is a normal ESR. That's what examiner keep asking you in the exam, right? What is the value in male, what is the value in female? What is the value in male? It is age divided by 2. Age in years, right? Not in days, okay? So similarly in female it is age plus 10 divided by 2. If it is more than that, so it is very high, say for a 60-year-old lady, 60 divided by 2, 60 plus 10 divided by 2, it should be 35. If it is, say, 70, twice the normal. So you have to think in mind, are you dealing with a severe form of autoimmune condition, or there is an inflammatory process that is going on, or vice versa. I will give you a practical 12. Whenever ESR is more than 100,
what we will do is first rule out HIV before branding it as autoimmune. Right? ESR is not specific. Same with MAN2. Same with any test, I will say. But it is how you correlate with the clinical finding that matters. So with the picture, if you have a raised ESR that is so many times the normal, 2, 3 times, 2 times the normal, then you are going to pay more attention. Hope I try to answer it. Can I take another question?
Yes, sir, you are very nice. You should let that alone. Okay. Raj Gopal Govind,
Yeah. So, Dr. Ninja has asked, do you prefer 2-drug regime, azathioprine plus steroids, or 3-drug regime, azathioprine plus cyclosporine steroids? Yeah. So, right. So, in our Indian scenario, steroids plus azathioprine most of the time is going to be helpful. Very rarely we have combined a third drug, cyclosporine, along with that. Although with the advent of TNF alpha inhibitor, to make it easy for you, several newer Indian companies have come with a newer simulator for biologicals, which we call as biosimilars. So the cost has come down drastically, and they give, to make people buy any drug, what we need to do is give offers, right? They give offers, 2 plus 1, 2 plus 2, 2 plus 4, so many offers are there. So with that, the biosimilars are picking up, and a lot of our patients are on biosimilars, right? Adalimumab is better in my experience with less side effect than infliximab. Agreed, sir? Yes. Why corticosteroid is not drug for visits? Our standard book authors have mentioned as topical systemic steroids. Because visits is known to be steroid resistant. Steroid standalone will not help you because it is a T-cell mediated disease, it's an hyperacute disease. If you only steroid, after some time you will get what is called a subacute response. So whenever we give for any uveitis steroids, the astute clinician need to look or pay attention how much the response you are going to expect after treating with a particular dosage. So if it is a suboptimal response, we always think Behcet as a first in our mind. Of course, there are other possibilities like are we dealing with a fungal uveitis, are we dealing with an infectious uveitis, all that in mind. But Behcet is characteristically known to be suboptimal. Thinking ulta, thinking opposite, name a disease is going to be supraoptimal response to steroid, it is going to be sarcoidosis. So you have a magnitude of response which you are expecting, the response will be much more than that. Sarcoid is known for that. So you have said that all standard books also say that steroids standalone are not useful. We need to give, in addition to steroids, other molecules like immunosuppressants and biologicals. So that is the commonest mistake people think. Anyway, it is give steroid, close your eyes, forget the diagnosis, anyway it is going to be steroids. So no, Behcet's steroids alone will not help. See, we have a lot of patients who are treated elsewhere, gone to multiple hospitals because they know that steroid. Ultimately, it will go for glaucoma, it will go for hell number of complications. Neovascularization, ischemia, unless you pick up early the diagnosis, start treating, it is not really going to help you in the long-term outcome. Right. Hope I answered it. Acute and chronic Behcet's management, yes. Acute, I said, yeah, steroids, infliximab. Chronic, once you have to be very, very careful going for the maintenance dose of steroids as well as the immunosuppressants. Of course, the immunosuppressants are going to help. When to stop biologicals, nobody knows. Long-term results are awaited. Chronic Behcet's is going to be tailor-made based on the magnitude of improvement we are going to see, as well as the severity of the disease, as well as the multiple parameters we are going to look at it. It's not going to be very single. So is HLA B5 and synonymous with HLA B5? Many books have mentioned as association. No, because there is something called actually B52. B52 is also there in visits. In fact, B52 is more commonly seen than B51. But B51 is very specific for visits, right? For confirming diagnosis, we would recommend vitreous biopsy and do PCR. PCR for what? What primer? So in the COVID era, for everything you can do PCR, right? So it's a non-infectious stuff, right? We're going to do primer for what? It's not a TB where you have a primer. It's not an infection where you have a primer. It's not a malignancy, you have a primer. So there's no role for PCR in visits. So if you may do PCR if you want to rule out the differential diagnosis. As you said, the first challenge for any uveitic clinician is going to be ruling out ARN. So if you are strongly suspecting ARN, maybe you could do PCR for the viruses. I assume that you know the causative for ARN. It is HSV, BCV, anything, sir? CMV, EBV. All these could cause ARN as well, although they are very rare. So all these primers could be used to rule out the differentials, but per se, actually, we can't do HLA from the vitreous and do all these things. So PCR has got no role. Because in acute stage, you can't differentiate from infectious. Yeah, thank you. Yeah, as you have written. What is it? Yeah, because of the drug interactions. So the efficacy is, because each of the drug, when we combine, the efficacy is going to be altered. So the efficacy is going to come down drastically and it defeats the real purpose. Is the presentation the hypopyan uveitis common visits? Yeah, it can be there, but more importantly, don't just say hypopyan. Find out whether it is mobile or immobile. Actually, B27 positive visit. Yeah. Actually, B27 is less common, but in visits, but it has been because our patients, they are not affording to do the actually B27. So actually itself is costly. If at all you want to do HLA in visits patient, it is going to be actually B51 and not actually B27. Yeah. Any other oral queries? Yeah. Any other queries? Yeah. Yeah. If there are no queries, you can end my presentation and talk. Hope it was interesting for you all. And you can always text me later if you want to ask in private. Thank you.